Good afternoon and welcome to today's webinar. For technical assistance, please phone Redback Support on 1-800-733-416. To ask a question, please use the chat box which is located on the left-hand side of your screen, just to the right of the cogwheel. After typing out your question, hit Enter to submit. Questions will be answered at the end of the webinar. Without any further ado, I'll hand you over to Sarah to begin.
Thank you, Yonwoo, and welcome everybody to our first webinar for the Olive Wellness Institute today, looking at the med diet and research in Australia, particularly relating to the role of extra virgin olive oil. So we've had an overwhelming response to this session, and we do thank you all for taking the time to listen to this, and we hope that you find the session valuable. We certainly have a lot of content to cover today, and it's important, I guess, that we give our presenters enough time to do that, so I won't keep you much longer. I'll just do a quick introduction to each of the presenters and go through their bios just quickly and make sure that you are aware of who they are, and then I'll pass over to them to take the session on for us today. So we'll just go to the next page. So I'm sure that the majority of people on the line here are familiar with Professor Catherine Itsiopoulos, or if you're not, introduce you to her today. She's the head for the School of Allied Health at La Trobe University. And Catherine's got a wealth of expertise and experience. I guess I won't go through a full bio because it could take a number of minutes. But basically, she has more than 25 years of clinical, academic, and project management experience. And she is our esteemed chair of our Olive Wellness Institute advisory panel. We're very pleased to have her on our team, and we're very fortunate to have her time today in presenting this session for us. So Catherine will speak to us first. And then we'll be followed by Dr. Flavia Fayet Moore. So again, we're very lucky to have Dr. Fayet Moore on our advisory panel for the Olive Wellness Institute. Flavia is a registered nutritionist and an APD as well. And Flavia runs Nutrition Research Australia. So you might see some of that throughout her presentation, because we've worked with Nutrition Research Australia to conduct some really interesting work, which Flavia will take you through today. So without further ado, I'll pass through to for the next slide for Catherine to present. And as Yonwoo mentioned earlier, we'll hold questions until the end of the session. And those that we can't reach in terms of the volume of questions, we'll send around a Q&A document by email to provide you with answers to all of the questions that we're provided today. Thanks very much, and hope you enjoy the session.
Thank you, Sarah, and thank you for the opportunity to be presenting today. It's an area that I'm very passionate about and have spent a large part of my career working in, and that is Mediterranean diet research, and with a focus on extra virgin olive oil being one of the key ingredients. So I'm beginning with a slide that illustrates a timeline of foods introduced into the Mediterranean, and I guess for many of you it will be well known that there is a Mediterranean triad of wheat, wine and olive oil, which dates back to 5,000 years BC. So extra virgin olive oil was very much part of the Mediterranean diet 5,000 years ago, when there is fossil evidence from olive oil trees in the region to show that. But it's quickly spread across the Mediterranean around the world, as we've seen. And wheat and wine being another key ingredient. But what I've added there are legumes and wild edible greens, which are very much part of the plant-based Mediterranean diet, and they do date back thousands of years. So I think we are probably 5 groups of foods, not just triad. Then we move on to the impact of the Ottoman cuisine in the 1400s, and you'll hear oftentimes a lot of words that are Turkish in the Greek cuisine, kefte or kofte, depending on how you pronounce it, and Turkish coffee, Greek coffee, Arabic coffee. It's that finely powdered coffee that is enjoyed in the Mediterranean and drunk black, short and black. Then we move to the 1500s, and a lot of these foods are commonly thought of as traditional Mediterranean, and they are if we think about 1500s beyond. But they were introduced by the explorers that went to South America and then came back to Europe in the 1500s. So the tomato, which is so commonly Mediterranean, chilies, citrus fruits, potatoes, eggplants, were all introduced from South America, and we thank the South Americans for the richness of these foods, which are very Mediterranean today. I've got an arrow across the tomatoes, an interesting story, and that is that when tomatoes were introduced to Europe in the 16th century, they were not taken up by all areas, and the aristocrats in England avoided them, thinking that they were poisonous. And the theory goes that the aristocrats were consuming tomato products, tomato juice and tomato sauces in lead or pewter goblets and plates, and because of the acidity of the tomato, that broke down the lead, and the belief is, or it's a theory, that the English were being poisoned by lead, and it wasn't the tomato itself. However, the southern Mediterraneans didn't have lead utensils, so enjoyed tomatoes freely and continue to do so till today. And the last point I want to make about the French cuisine is that you often see a lot of creamy additions added to the Mediterranean foods, and a classic is pasticcio, which is the Greek version of lasagna. Now, bechamel, which sits on top, it's made of butter and flour and milk, is not traditionally Greek. It has come from the French cuisine, but is enjoyed by Greeks. So an interesting look at the Mediterranean diet and the various influences. Let's move to the science now. In a large review called an umbrella review, which was completed by Dinu here as first author, but Francesco Sofi, who has completed multiple systematic reviews and meta-analyses on the impact of adherence to a Mediterranean diet and protection from all of these conditions. So what this meta-analysis or these studies rely on is being able to assess adherence to a Mediterranean diet, and this was done using the Mediterranean Diet Score developed by Antonia Itsiopoulos and our own Andivoni Korisblasov from Australia and Mark Volkers. So that score enables lots of studies around the world to assess adherence to a Mediterranean diet, and what we have here are multiple meta-analyses, therefore umbrella review, and of observational studies and randomised controlled trials investigating the link between med diet and 37 different health outcomes, over 12 million subjects involved. So large body of evidence, and we can see a reduction in cardiovascular disease, diabetes risk, neurodegenerative diseases, overall mortality, reducing cancer overall, and dementia and Alzheimer's. And in the next slide, there is a more detail, hard to see, but you can see in the green, there is convincing evidence, strong green, dark green convincing, and lighter green highly suggestive evidence for Mediterranean diet adherence and protection from all these conditions. So mortality, cardiovascular disease, coronary heart disease, myocardial infarction are all represented here, diabetes as well, neurodegenerative diseases, and then we have suggested for many of the other areas on this map. So pretty much strong evidence overall for benefits of a Mediterranean diet. We might now move on to describing what is the Mediterranean diet, and this slide here illustrates that it is a plant-based diet with a plant-to-animal food ratio of 4:1. And often in my education, whether that be trials or with patients, I describe a plate where we see 4/5 of the plate plant foods and only 1/5 of the plate animal foods. And that gives the right ratio, and that's in one dish, but overall in the day or over the week, we should aim for 4:1 to achieve the plant-to-animal food ratio of a Mediterranean diet. If we did that, we would be able to enjoy the high quantity or concentration of antioxidant and anti-inflammatory nutrients that are found in a Mediterranean diet. So in summary, a Mediterranean diet has an ideal ratio of fat, carbohydrate and protein, and that makes it ideal for the management of multiple conditions including diabetes. It's rich in anti-inflammatory nutrients. It has a low environmental footprint because it's high in plant foods, and it's economically accessible because it's high in plant foods. So I'll be able to talk to all of those points through the presentation. So now I want to move to the benefits of a Mediterranean diet and whether it's transferable to non-Mediterranean populations. So in the earlier slide I showed you in the umbrella review, that's an international group of meta-analyses, which does include some evidence from Australia, but it is mostly, I guess, heavily influenced by data from Europe. But what we've done in Australia over the last 20 years is looked at the implementing this diet in Australian populations. And this slide here shows La Trobe University with multiple collaborators investigating the impact of a Mediterranean diet against many conditions. So I will talk about secondary prevention myocardial infarct in a moment. I want to just mention that we are launching a study called MediBrain, which is reversal of early cognitive decline in patients with type 2 diabetes by implementing a high fish oil Mediterranean diet, and that is in planning or about to be launched. We have published reversal of fatty liver. I will be talking about that shortly. We have published data on reversal of depression, the SMILE study, in the last couple of years in collaboration with colleagues at Deakin University, demonstrating that a Mediterranean diet, a modified Mediterranean diet, was effective in reversing depression in patients with confirmed depressive symptoms. So very exciting research there, and that's also been demonstrated by colleagues in South Australia, Natalie Paletta, in the Healthy Med study. And most recently, and it has received a lot of media attention in the last couple of weeks, and that is the AUSMED asthma study, where we demonstrated improvement in asthma inflammation, lung inflammation in asthma, children with asthma, and I have a slide on that. So multiple areas of research in Australia dating back over the last 20 years. So how does this diet work? And when I started working on the Mediterranean diet over 20 years ago, we thought it was all about fatty acids and the fact that extra virgin olive oil produced an optimal fatty acid profile. That is important, of course, but it's not just about fatty acids. And fatty acids encompass obviously the high omega-3 fats in fish and plant sources as well. It isn't just about fatty acids, it's about the combination and the synergistic effects of all of those anti-inflammatory components, of which extra virgin olive oil includes a lot of biophenols, but they're found in many other foods as well, as per the earlier slide I demonstrated. So we now understand the Mediterranean diet to be an anti-inflammatory diet. And we know that many chronic diseases begin with low-grade chronic inflammation. And we can measure this low-grade chronic inflammation by all of these intermediate markers that we see on the right here. What this picture shows here is, and the story is about diabetes, or the impact of visceral fat, and the fact that visceral fat is highly metabolically active. It produces a lot of inflammatory components, and hence is associated with increased risk of diabetes because of the release of these inflammatory markers. And we believe many other chronic diseases begin by low-grade inflammation at the vascular level. So what we see here is a fat cell producing all these inflammatory markers, and the anti-inflammatory Mediterranean diet provides defense against these high markers of inflammation. So if we move on, we've got a number of studies we've published. Many of these are I think I've mentioned already, and I'll address them in a moment in separate slides. So this one is the AUSMED heart trial. We have published the pilot, and I've got a couple of slides on the pilot. This is secondary prevention of myocardial infarct using a Mediterranean diet compared to a standard low-fat diet. And we, as I mentioned, we have completed the pilot. So this is the study protocol which we published recently. The pilot was completed by Dr. Hannah Ma, who recently graduated from her PhD. And what this was is a multi-centre parallel randomised controlled trial in 2 hospital settings in Victoria, investigating the impact of a Mediterranean diet versus a low-fat diet, followed for 6 months on intermediate markers of cardiovascular risk. So patients were mostly male, average 62 years, 30% had diabetes, 41% metabolic syndrome. So we can see patients with cardiovascular disease, lot of high morbidity. So a Mediterranean diet here impacting not only on the cardiovascular disease risk reduction, but also in managing the diabetes that we see in this patient population. So we successfully completed the pilot, and a lot of the data is now published. What we see on this slide is the comparison of the 2 diets. So the low-fat diet is based on the National Heart Foundation and Australian Dietary Guidelines, promoting whole grains, vegetables, fruit, lean protein, low-fat dairy, limit high fat, sugar, salt, and limiting salt, and that is a typical healthy approach to managing cardiovascular disease. And these are the energy ratios in this diet, and you can see it's moderately high in carbohydrate, low in fat, with a good balance of fatty acids and 20% protein. What we see on the right-hand side is our Mediterranean diet model based on the traditional Cretan diet and the Hellenic Dietary Guidelines, promoting extra virgin olive oil as the key fat in the diet, and other healthy fats, nuts and fish is in there as well, whole grain vegetables. The vegetables specifically focusing tomatoes, leafy greens, onion, garlic, and high use of herbs and spices as well, and snacks of fruits and fermented dairy like yogurt, red wine, only when participants are consuming alcohol and in moderation, of course, and limiting red processed meats, commercial sweets, dairy spreads. So there is some overlap, obviously, but some key differences, and that being the high volume of extra virgin olive oil, as well as some of these other ingredients. And we can see the energy ratios are quite different. A moderately low carbohydrate, 35% of energy from carbohydrates, high fat, 40% energy from fat, but a much higher in monounsaturated fat and balance relatively balanced for protein. And we published this diet recently, and Eleanor George, who graduated from her PhD, published that earlier this year. So on the next slide, we can see data from the AUSMED heart trial demonstrating that we achieved adherence to a Mediterranean diet in 6 months in these participants. So 64 participants completed the trial. This is the AUSMED heart trial pilot that Hannah Ma completed her PhD in. And what we see in the blue is adherence to these food groups in the low-fat group, and in the orange, adherence to these food groups in the Mediterranean diet group. And this is data for 6 months. We did provide some produce in the Mediterranean diet arm. We provided extra virgin olive oil for the duration of 6 months. We provided nuts and a hamper of food, sample food. So tinned fish in our case here, some yogurt and other ingredients. So we did demonstrate some key elements of the Mediterranean diet, provision of these foods, and in the alternate arm we provided a voucher for that participant as an incentive to continue on the trial. We had a very low dropout rate, 10 to 15%, which is quite pleasing. So we can see adherence to olive oil, extra virgin olive oil, that is, at 6 months was high on the Mediterranean diet as expected. Some of the vegetable and fruit differences were similar, and that just shows the overlap. That the Mediterranean diet and the low-fat diet does overlap in vegetable and fruit recommendations. Legumes were higher as well. Seafood's higher on the Med diet as expected. Red meat lower on the Med diet as expected, which was great, and yogurt higher on the Med diet. So these changes were maintained at 12 months, even after we stopped providing those sample foods. So what we show with this paper is that a Mediterranean diet is able to be implemented in the Australian population with cardiovascular disease, and that this is maintained at 12 months. We then looked at the Mediterranean diet using a dietary inflammatory index. This index is a novel way to look at diet, and it's a way of assessing diet inflammatory potential against 45 diet parameters, and it's a tool developed by Shibata and colleagues from America, and we collaborated with them in publications, which I'll show you, and in the AUSMED heart trial pilot. So when you apply data from dietary intake or a modelled diet using this formula, the diet will score a +8 if it's extremely pro-inflammatory, and you can see the nutrients here that score a plus in pro-inflammatory. That's not ideal. It's in the red, and in the green we have anti-inflammatory, and it would score a -9 if it was very high in anti-inflammatory. And you can see some of this is a combination, the 45 diet components like onions and nutrient components with anti-inflammatory potential like turmeric and vitamin E and flavones and MUFA. So this is the score, and it's just revolutionised the way that we can measure diet. And what we did was, and Hannah did this in combination with the Shivappa, is to look at the modelled meal plan. And what we see in the red is the Mediterranean diet modelled meal plan is highly anti-inflammatory. And the low-fat meal plan is not as anti-inflammatory as expected. So what we show here is that the model diet meal plan, the Mediterranean diet scores much better in its anti-inflammatory potential than the low-fat diet. And then on the right, this is the actual data from the participants. At baseline, we see the Mediterranean diet participants. There's not a lot of difference here. They're pretty matched at baseline, the low-fat diet participants to the med diet participants, and this is based on their diet diary data. At 6 months, though, we see the Mediterranean diet participants' diets are significantly more anti-inflammatory than the low-fat diet, which started to actually turn in the other direction. Part of that is because the low-fat diet was not as adhered to, as well as adhered to as a med diet, which shows us that the low-fat diet is not that easy to adhere to. But what this also shows us is that med diet participants followed the anti-inflammatory med diet. Their diets were more anti-inflammatory, and we also show that this drop in inflammation, or the anti-inflammatory level of their diet, was associated with a significant fall in interleukin-6, which is one of those inflammatory markers that we want to see a drop in. So very exciting data from the pilot published by Hannah. So a couple of slides in reversing fatty liver, which I mentioned in my opening slide. And this is a data from a couple of years ago where we looked at 20 participants, put on a Mediterranean diet and a high carbohydrate, low fat diet. And there's 3 panels here, and I'll explain them in a moment. And so we randomised them, participants who had biopsy-confirmed fatty liver. We randomised them onto the Mediterranean diet or a low-fat, high-carbohydrate diet, followed them for 6 weeks, and then crossed over. And what we can see in panel A is that those on the Mediterranean diet, and that's the light blue that I'm indicating now, had an almost 40% drop in intrahepatic lipid following 6 weeks on the Mediterranean diet, and those on the high carbohydrate, low fat diet only had a 7% drop in intrahepatic lipid. So the Mediterranean diet was much more effective at reducing fatty liver in participants who had fatty liver on entry into this trial. What we also found, and I'll explain panel C, is that those on the Mediterranean diet, the light blue, had a 35% fall in fasting insulin, whereas those on the low-fat, high-carbohydrate diet did not show any change in fasting insulin. And we know that fatty liver is associated with insulin resistance and therefore is associated very strongly with the development of diabetes. So a trial showing an effective reduction in fatty liver, and this was a small trial a few years ago in the Journal of Hepatology, and in the Medina trial, which was done by Eleanor George, published this year, and Eleanor completed her PhD in this area. We've actually extended the fatty liver trial. We've called it Medina, and this is another pilot of 25 participants looking at this condition, which is highly prevalent. It's asymptomatic. It increases risk of end-stage liver disease and significant problems like hepatocellular carcinoma, all-cause mortality, and of course diabetes, as I mentioned earlier. What Eleanor did in this pilot was recruit 25 participants and put them on a Mediterranean diet versus the high carbohydrate, low fat diet, followed them for a longer period of time, and then the 6 weeks for 3 months to look, and then again at 6 months to look at functional measures of liver function. And some of the early findings from Eleanor's study show that, as for the previous fatty liver study, we are showing improvements in fatty liver for those on the Mediterranean diet, as compared to those on the low-fat diet. So important, because these are small trials, that we demonstrate these effects in multiple trials. Just one trial is not enough. So as I mentioned earlier, this trial is about reversing or improving asthma symptoms. This trial was completed by Maria Papa-Michael in Athens. She's a La Trobe PhD student. Maria recruited 64 children aged 5 to 12 years with mild asthma, randomised them to a Mediterranean diet with 2 serves of oily fish per week, compared to usual diet for 6 months. So it's a parallel RCT, and at the med diet adherence for both groups, whether they were randomised onto med diet or the usual diet, was poor at baseline. We used the KidMed score, and both participant groups scored a 5 out of 12, showing that children in Greece are eating a poor diet against the Mediterranean diet score, as we would expect our children in Australia to be scoring poorly against the Mediterranean diet score. But at 6 months, we were able to improve their Mediterranean diet score for those children on a med diet plus fish. And what we also saw at 6 months were that the children that followed the med diet supplemented with 2 serves of fatty fish had a significant fall in fractional expired nitric oxide, which is a biomarker of lung inflammation. So that's quite exciting. It's preliminary results that shows mechanistically how a Mediterranean diet rich in fatty fish could improve asthma control in children and potentially in adults. So now moving to the cost effectiveness of the Mediterranean diet. I mentioned earlier the SMILE study, reversing symptoms of depression using the Mediterranean diet. Well, Rochelle Opie, in her PhD, demonstrated that, and she did cost modelling of 20 participants at the early stages of this intervention. She looked at the cost of food per person in the control condition who were following their usual diet, and calculated their food, weekly food cost to be $138 per week, and this is the megajoule cost per megajoule, versus the cost of the food per person in the Mediterranean diet intervention, $112 per week. So what she was able to demonstrate in this paper is that following the Mediterranean diet is cheaper, significantly cheaper than the usual diet for the participants, or the 20 that started on the SMILE study, and we hypothesised, and this is because she measured all of the foods in the 2 models, that patients on their usual diet, and these are patients with that were symptoms of depression, were spending a lot of money on snack foods, and we know that snack foods are quite expensive. Takeaway foods are expensive, but if we have a fresh cooked, healthy Mediterranean diet, which is plant-based, it can be a lot cheaper. And we did and this is Mary Lou Chatterton, who's a health economist on the SMILES trial. This is a full economic evaluation of the SMILES trial for the full 67 adults that were in the trial, that followed the trial for 12 weeks. And she looked at all of the costs and was able to compare to the control condition. Average health sector costs were $856 lower, and average societal costs $2,500 lower for those on the ModiMed diet compared to control conditions. So a significant improvement in or reduction in direct health sector costs and average societal costs for those on the ModiMed diet. And the cost differences were driven by lower health costs because less access to healthcare, less need to go to see an allied health professional when you are feeling better on the ModiMed diet, and lower unpaid productivity while on the ModiMed diet. So very exciting data from the SMILES trial. Extra virgin olive oil is central to the Mediterranean diet. So in the last few minutes, I just want to spend a little bit of time focusing on extra virgin olive oil. Now, when we look at Mediterranean diet interventions, there are 10 different principles we use to implement the Mediterranean diet. The number one principle is use extra virgin olive oil as your main added fat. And when we use extra virgin olive oil in all of our diet interventions, we use 60 mils or 80 mils a day, not just 5 mils a day, which is probably what the majority of the population have been using in the past. Well, certainly our trials have shown that. I want to refer you to the Olive Wellness Institute website that includes grades of olive oil. A question that I always get in presentations is, what is the difference between the different olive oils? Well, what this shows in this chart is that extra virgin olive oil is the highest grade of olive oil. It's highest in natural antioxidants and polyphenols, and is trans fat free. And then we move on to the different grades. Virgin olive oil is lower grade than EVOO or EVOO, moderately high in natural antioxidants, and it's less healthy than EVOO. And then we've got the lampanate, which is not fit for olive oil for consumption. But what we find in the market is the extra virgin olive oil and pure olive oil, which is refined with a little bit of extra virgin added, and there are significant differences between the two. In all of our trials, we recommend extra virgin olive oil. That's what we use, and we have there's a trial that I'm about to show where we're putting the extra virgin olive oil, high polyphenol olive oil, with a common pure olive oil that's on the market to the test to see how the two behave in terms of markers of inflammation. I'll refer you to the Olive Wellness Institute website for a little video of myself talking about the benefits of extra virgin olive oil in the context of a Mediterranean diet, and a preview of the Olive Wellness Institute website on the left there. So that can be accessed later. This research here, and there, I'll skip to the next slide, which is a study completed by Flavia, Guillaume, and Leandro Ravetti in a ISO-accredited laboratory to actually test the chemical and physical properties of different oils when you put them to the test in cooking. Now, one common misconception is that you can't cook at high temperatures with extra virgin olive oil, and the answer that I can give is that in a traditional diet, there's only one type of olive oil that is used in a traditional diet, and that is extra virgin olive oil. And that's occurred for centuries. So for Greeks, Italians, Spanish, other people of the Mediterranean diet, it's extra virgin olive oil that we use, regardless of the cooking. So what Leandro and Flavia did in this study was compare a number of different oils and put them to the test. They heated the oils to 240 degrees Celsius and then continued cooking them for 180 degrees Celsius for 6 hours, and found that at the end of this high temperature, or moderately, 180 is about what you would cook, with shallow frying, your casseroles, and oven cooking is mostly at that temperature. And what they found at the end of the study was that extra virgin olive oil was shown to be the oil that produced the lowest level of polar compounds after being heated for 6 hours, closely followed by coconut oil. So EVOO performed really well, and better than some other polyunsaturated fats, and canola is called out in particular. So it I guess puts the question to rest that you can't cook with extra virgin olive oil because it changes. The fatty acids remain stable. It's rich in antioxidants or biophenols, which protect the oil from oxidative damage, and we don't see a high production of polar compounds, which are of concern when oils are cooked to high temperature. So this paper also shows that we shouldn't measure the oil by its smoke point. We should be confident that an oil that is high grade is able to withstand the normal cooking processes. So I'll refer you to that paper for further reading. I wanted to also highlight that we have completed and published a meta-analysis of 26 studies comparing high polyphenol oil to low polyphenol olive oil with CVD risk marker outcomes, and found that compared to the low polyphenol olive oil, the high polyphenol olive oil significantly improved some markers of oxidative damage, melandialdehyde being one, oxidized LDL, total cholesterol, and HDL cholesterol were all better on the high polyphenol olive oil versus low polyphenol oil. So this is a meta-analysis of 26 studies done internationally, and this is why we think extra virgin olive oil is rich in phenolic compounds which impact all of these systems. And I don't have time to go through that detail, but and this is the last study I will refer to, and it's the study I mentioned earlier where we've just completed the meta-analysis and systematic review on 26 studies from around the world showing high polyphenol oil performs better than low polyphenol oil against cardiovascular risk markers. We are now doing this study here in Australia, and PhD student Katerina Itsiopoulos and Sid Shivanta, honours students, have completed some pilot work comparing these two oils. This is the study design. We are looking at recruiting 50 participants. At this stage, we are about halfway. So we're randomising participants to high polyphenol olive oil with a dose of 60 ml a day, 3 to 4 tablespoons, versus low polyphenol olive oil. The participants and the investigators are blinded to the olive oil, so they don't know which one they're getting. We then have another washout period, and then we cross them over. This is a randomised crossover trial, the highest grade of trial that you can do in a clinical trial, and these are the polyphenol differences in the oil. There is a 10-fold difference between the concentration of biophenol in the high polyphenol olive oil versus the low polyphenol olive oil. So we are expecting to see differences. We're measuring all of these things, and as I mentioned in one of my opening slides, we are interested to see a drop in pro-inflammatory markers following the consumption of the high polyphenol oil, and an increase in anti-inflammatory markers, if possible, in following the high polyphenol olive oil, and of course markers of vascular, blood pressure, etc. So some early findings. What we found here is the extra virgin olive oil, the high polyphenol oil consumption significantly lowered peripheral systolic blood pressure in a small pilot that was completed by the honours students. This is the first of its kind study that showed also a phenolic effect. The effect of the high polyphenol oil had a significant effect in dropping interleukin 33, which is an inflammatory marker, or in raising interleukin 33, my apologies, this is an anti-inflammatory marker. And what we need is a larger sample size, so we need the study to complete over the next year to see whether the high polyphenol oil, in fact, is going to improve the anti-inflammatory markers and reduce the inflammatory markers, and also continue to have an effect on blood pressure. Conscious of the time, this is my concluding slide, and I just wanted to say that the Mediterranean diet, and this is data from one of the long-living islands, IKARIANS, is a Mediterranean diet in the context of a lifestyle that we see in a rural setting like IKARIANS, which is a very mountainous island, is important in contributing to the longevity. This is an island where people live way beyond the night. They're 90 years old. They have low levels of stress. They have a very social active life. All of these factors are very important, but they have a high plant food diet focused on local foods. Extra virgin olive oil that they produce there is of key importance. They do consume meat. It is free range, and goats are common, and they have high purpose in life. So this is not just a menu. It is about a lifestyle. We put some of our learnings into cookbooks, which we use to educate our participants. And thank you to all of these collaborators. So I'll leave it there. And thanks, Sarah, and all of you for listening in today, and handing over to the next speaker.
Thank you. Thanks, Catherine. It was fantastic. As you can see, we've got a lot of stuff to share on extra virgin olive oil, and what we'll do post the session is we'll send you a summary of all the research we've covered today in a nice simple table so that you can get a chance to digest it a bit further. I'm just about to pass to Flavia, but conscious we're a bit over time, so I just wanted to flag that we may go 5 to 10 minutes over time. If you do need to drop off, that's fine. We'll be sending a full recording of the session to you afterwards. And so now I'd just like to pass over to Flavia. We may not be able to take questions at the end, but again, we'll send full question and answer documentation through within the next 24 hours. So over to you, Flavia.
Thank you, Sarah. So Thank you so much for that very informative presentation. I'm sure everyone is completely bombarded with so much amazing information, but unfortunately, I'm about to bombard you yet again, so brace yourselves. My purpose today really is to give you an overview of the science using systematic literature reviews and meta-analysis on where the science is at in terms of olive oil and cardiovascular disease prevention. With that presentation, I'm also going to give you some background on the lifestyle medicine approach. So that slide from Catherine was just perfect because it's really reminding us to look at the totality of the diet and the environment and everything else in the context of what people are actually consuming. So lesson 101 of lifestyle medicine starts now. I invite you to stand. I'm actually in tree pose as we speak. I work standing. And if you're not already standing, I invite you to stand to listen to the rest of the webinar. Or I invite you to get your mobile if you're already on it and go for a walk. And thirdly, maybe after you get some fresh air, you might also get some vitamin D as well. So my presentation is about 30 minutes, and I hope by the end of this presentation that you'll have a better understanding of the totality of the science, how much research based on reviews exists, and be able to make some recommendations that are based on the totality of the science to give you some confidence where there's consistency, but also to identify gaps and issues with the literature. So to give you an overview of what I'm going to be presenting about, we're going to first start on that lifestyle medicine approach relating to cardiovascular disease. Then I'm going to talk about the approach that we actually took. So obviously you can see there are so many papers published in this area. So how do you actually, as a practitioner or a health professional, how do you actually interpret all that science? So we'll talk about the approach that we use to help you interpret that science. Then I'm going to give you the results of the science on olive oil and cardiovascular disease, as well as on the med diet and cardiovascular disease, since as Catherine mentioned, olive oil is the extra virgin specifically, is the primary fat in the Mediterranean diet. Then I'm going to talk about some potential mechanisms briefly, and the other risk factors in the science on those other risk factors for cardiovascular disease. It's important to always highlight the limitations of the research, and I'll leave you with some concluding remarks and take-home messages that you can go off and think about. So now the first step of the presentation really is for you to close your eyes and for you to just imagine that you have 9 of the most important people in your life gathered in a room with you. And now consider this, that about 3 of you are going to die from a single disease. And yet, there is a pill that could save the majority of those. And that pill is perfectly natural, it has minimal cost, and it actually has a lot of side effects, but they're all good for you. So would you take it? Would you recommend that all those important people take it? Well, the disease I'm talking about is actually cardiovascular disease, and the pill indeed exists, and that's lifestyle medicine. So what is lifestyle medicine? For those of you interested in learning more, you can read the Bible. This is the book published by Gary Egger, which is the foundation of the principles of lifestyle medicine. I encourage you to buy it. Gary can give me the profit cut later and read it because it's quite applicable to lifestyle medicine. So how is lifestyle medicine any different from regular medicine? It's really taking people from that clinician to patient-centric. And it's applying not only medical principles, but environmental, behavioral, and motivational, so we can help manage those lifestyle-related health issues like cardiovascular disease. And the focus is really on the patient's self-care and self-management of that disease. So we all know some of the key lifestyle determinants of disease. We know it's smoking, poor nutrition, physical inactivity are really the top 3. But it's really important to consider that all those lifestyle determinants are interlinked. So perhaps someone is more likely to smoke because of their social context that they're in. For example, in Europe, it's still quite widely accepted to smoke in restaurants. Whereas, for example, in Australia, it's not. So it's important to have that cultural, that social aspect when you're making lifestyle recommendations. And inactivity, as I mentioned, let's everybody stand up because we're all probably staring at a computer right now if you're not looking at the slides. And our occupation leads us to have a less active lifestyle. So from a lifestyle medicine perspective, it's important that as a practitioner, we assess the totality of that person's social, cultural, environmental aspects when we're making recommendations. So the key thing about lifestyle medicine is really about facilitating change, so helping to coach and to motivate people to change those unhealthy behaviors into healthy behaviors. And how do you do that? Well, it's all about nudging, so obtaining the skills as a lifestyle medicine practitioner to motivate, to nudge, and to encourage your patients to have some self-care. So there are three principles to the skills that you obtain: you assess, you assist, and you arrange. When we're talking about assessing, we're assessed, for example, is their diet a major culprit for cardiovascular disease risk factors? And if it is, then we want to measure and assess what the food intake is like so we can make adequate recommendations. We assist in treating other comorbidities. We're not just focused on one aspect, not just diet, but also other risk factors for cardiovascular disease like physical inactivity. We help educate them on the importance on how to actually make those changes. We assess if they're ready for change, and we assist them into becoming ready for change. And then finally, you arrange a referral to the appropriate healthcare professional. If, for example, you're a GP, you might refer to see a dietitian or other health professional to discuss these factors. You might discuss with other health professionals how to motivate that client if you have a multidisciplinary team. So this is kind of the overview of lifestyle medicine for you to think about during the presentation. So in terms of cardiovascular disease, it's Australia's largest killer, unfortunately, and it's around the world as well. But the beauty is that 7 out of 10 visits are lifestyle-based. So there is a huge potential to actually reduce cardiovascular disease, because we know that 80% is actually preventable. And we know that it's preventable through modifiable lifestyle habits like physical activity and the choice of foods that you have. And some risk factors that we can also monitor includes high blood pressure, high BMI, and dyslipidemia. But unfortunately, this is what we're working with. Most people actually want the pill, and they don't want the lifestyle medicine pill. They want the pill that will prevent them from having to do anything. And diet is really kind of the number one focus in lifestyle medicine if you had to prioritize, because it's the number one cause of poor health. We want to know, can olive oil actually be a key food for cardiovascular reduction? If we are going to recommend olive oil, and specifically extra virgin olive oil, with a lifestyle medicine approach, what you have to think about is what happens to that person when we recommend for them to have extra virgin olive oil in the diet. Do they like the taste? How is it going to affect the flavor of other foods? How is it going to affect their intake? Are they displacing things that are less nutritious in their diet, or are they consuming things that are more nutritious? What's the eating environment? So do they eat out 3 meals a day, or do they actually have time to use the olive oil and cook something? What is the cost? So in terms of the Mediterranean diet, we've seen that from Catherine's presentation that it actually costs less. That's important. Perhaps that's a motivational factor for someone that doesn't have the money to spend on food. What is the availability? So if you're going to recommend a Mediterranean diet, which has a high seafood consumption, even though Australia is blessed to have such a vast coastline, there's still people that have very limited access to seafood. And there are very few people that actually enjoy eating it. So from a lifestyle medicine approach, you have to take all those things into consideration before making a recommendation or when making that recommendation. We know in terms of nutrition, the strongest evidence from a lifestyle medicine approach is the Mediterranean diet. And it's really important that we focus on foods, not nutrients, and whole person approach, because even when Catherine was talking about low-fat diet, you really want to talk about the Australian Dietary Guideline diet or the National Heart Foundation diet, because we're still a little bit focused on nutrients more than we are on total dietary approach. So what is the approach that we actually took to do this, summarizing all of the science for you on olive oil and cardiovascular disease? So we decided to obtain all the systematic literature reviews. They had to be systematic from the year 2000 to June 2018. And we decided to have that 10-year cutoff because any previous individual studies published prior to that would have been captured in any new science or any new systematic reviews. We actually summarized the science on 10 health outcomes, including cardiovascular disease. So you can actually go off and read about that. Catherine mentioned as well all the other health outcomes and diseases that a med diet is associated with. So many of those came through on our review. We then chose the most recent and highest quality SLR evidence. Obviously, being time poor as health professionals, we can't possibly read every single study there, but we have listed every single study for you if you are interested in some light reading before bed. But we chose the most recent, the highest quality, and the most relevant SLR to actually read in full and summarize for you. So that includes olive oil and med diet in relation to CVD, but also its biomarkers, so inflammation, lipids, blood pressure, and weight loss. We prioritize studies that looked at olive oil over studies that looked at med diet. For example, if there was olive oil specifically, we used that study. The most recent, the one with the most outcomes relating to that health outcomes. If they did a quantitative assessment, so if they did a meta-analysis, then we included that over a study that didn't have a meta-analysis included. We looked at the quality of evidence, so we prioritized RCTs over SLRs that summarized cross-sectional evidence. If it started getting really close, and it was close for some of them, then we looked at the impact factor of the journal that it was published in and chose the one with the highest impact factor, or the study with the greater number of citations, which is a bit of an indicator of the relevance of that research in this area. We then looked at the study type. So when we chose the one study, we looked at what type of studies were included in the SLR. We looked at what was the diet or the food, what was the comparator food, if they specified it, what were the outcomes, what was the population. Because again, it's very important to know what's the population, if it's Mediterranean only, if it's from all over the world, and so on. Key results, and if they did a qualitative assessment of the studies, we specified what was done and what the results were. So the summary of the evidence, you can actually look at all the research that we did. It's pretty much on the Olive Wellness Institute website. You just click on extra virgin olive oil, then you click on systematic literature reviews, and there are fact sheets for each one of the 10 health outcomes. So you can actually just click on them and read all the evidence. And within each fact sheet, there's also the list of all the other health outcomes, the other reviews that were related to the health outcomes. So that list is what we thought were related to that outcome, but some reviews might relate to others as well. But if you download all the 10 fact sheets, you have all the evidence published to June 2018 of the SLRs and meta-analysis on olive oil and the Mediterranean diet. So again, this is the fact sheet on inflammation, and that's the fact sheet on cholesterol and blood lipids. So what did we find in terms of olive oil and cardiovascular disease? There were 2 SLRs that were found. The one that we chose to be the umbrella one that covers the most of everything was an SLR that combined 1 clinical trial, 5 cohorts, and 3 case controls. So relatively small number of studies, about 9 studies were included. They clearly showed that there was a significant reduction in cardiovascular disease for an additional 25 grams of olive oil, and that reduction of risk was 18%. When they did subgroups and specifically looked at stroke and coronary heart disease, it was only significant for stroke, and that was a higher reduction at 24%. So perhaps some of that reduction is being driven by stroke, but also there are lots of other things to consider in that study. For example, which we found pretty much for most of the research in this area, unfortunately, they do not specify the type of olive oil. So there's a mixture of refined, of virgin, of extra virgin, all combined and reviewed, and a meta-analysis is done. So not often people specify the quality or the grade of the oil, so it's important to consider this as well. So there are many reasons perhaps why there are differences in the risk reduction, but it was, overall from a cardiovascular disease prevention, it was significant at 18%, and specifically for stroke was significant. Another interesting aspect of this SLR is that they were all in Mediterranean countries. So it'd be interesting to have more research. Hopefully, as Catherine publishes more and more in Australia, we'll have those studies to be added to the SLRs to see what the differences are between Mediterranean and non-Mediterranean countries. The other study, we didn't look at that one in detail, but since there are only 2, I had a brief look at the results of that study as well, and for the purpose of this presentation, it was only on cohorts, so it's a bit nicer that it's only one type of study summarized, and they found a similar risk reduction of cardiovascular disease to the study by Martinez-Gonzalez. So then, in that same cardiovascular disease section, you have a few other studies, and they're all on the Mediterranean diet and cardiovascular disease reduction. It's really important that all the evidence that was included there has to do with incidence and mortality. So it's not to do with risk factors. It's specific to clinical outcome or clinical benefit of a reduction in cardiovascular disease incidence and mortality. So when we look at the Mediterranean diet, there was a review done by Mente in 2009. And then this review was a review and meta-analysis of prospective cohorts and RCTs with at least 1 year follow-up. So they're very like a long-term follow-up. And what they did is that they used the Bradford Hill guidelines for measuring causality. So they looked at the observational evidence and said, does the RCT evidence match the observational evidence? Both med diet and other high-quality diets ranked as very likely to provide protection against coronary heart disease specifically, but the med diet was the only one where causality was there. Then the latest, most recent evidence on the med diet and cardiovascular disease is from the study by Rosado, 2017. They included 29 studies and showed that there was about a 30% reduced risk and mortality from cardiovascular disease. Now, that study, the risk reduction is at the same level as it was shown in the PREDIMED trial, which was 30% decreased risk in the extra virgin olive oil arm. But it's pretty strong, the evidence in terms of the med diet and risk reduction of cardiovascular disease. Now, obviously, the Mediterranean diet is not all about extra virgin olive oil. In this meta-analysis, they compared overall what was the risk reduction from RCTs, and it was about a 40% decreased risk. And when you think about risk, like drugs can't even reach that high, right, with risk reduction. So that's why I want you to think about a dietary pattern and lifestyle medicine as a pill, because the risk reduction is so high compared to any other medicine or anything else that we can do to prevent cardiovascular disease. So all the different components are there. You can see that olive oil had the greatest reduction, but it was overall, the meta-analysis attributed that reduction to olive oil, but also to fruits, vegetables, and legumes. Unfortunately, they didn't include nuts in this particular pooled risk ratio analysis. So then when you look at other foods and other food groups, there's this meta-analysis that was done, and it's actually from a comprehensive review looking at both cardiovascular disease, diabetes, and obesity for policy prevention to guide where policy should be changed. And in this review, they combined all these food groups, did not include olive oil, but it shows that the risk reduction from any singular food group is at around 0 to 25%. So extra virgin olive oil and olive oil, it's at a level that it's equal or superior to each of these other individual and single healthy food or food groups. Now, in this is from the same Mozaffarian paper from 2016, the comprehensive review. I love what they showed here. It really shows the whole dietary pattern approach. On the left, you've got the Women's Health Initiative study, and on the right, you've got the PREDIMED. And these are probably the two most largest, longest duration trials that have really ever been performed in nutrition. On the left, the recommendation was a low-fat diet, so nutrient-focused. And on the right, the recommendation was the Mediterranean diet with a nut or the extra virgin olive oil arm. And what's interesting is that both diets actually resulted in dietary change. On the left, in the Women's Health Initiative, they actually had a low-fat diet. And on the right, the adherence to the diet wasn't as significant, wasn't as drastic, but only in the dietary pattern approach, there was actually a result in a clinical benefit and then a reduction in cardiovascular events. So it just shows the importance of making recommendations from a dietary pattern perspective as opposed to just low-fat diet perspective. And I encourage us to, researchers to, even when comparing to the med diet, not to compare to a low-fat or low-carb or high-protein, to actually compare to other dietary patterns as well. We need more research that compares pattern to pattern as well. And what you call it obviously makes a difference in how people interpret. So what are some of the other potential mechanisms of action for why olive oil exerts this benefit on cardiovascular disease reduction? And why does the Mediterranean diet have this effect on cardiovascular reduction? So there are 4 other health outcomes that were included in our SLR summary that relate specifically to the mechanisms of action, but there are obviously many others. These are the 4 that relate to CVD that we actually summarized. So the first one is reduced markers of inflammation in endothelial function, a beneficial effect on blood lipids, reduced blood pressure, and weight loss with the Mediterranean diet. And I'll go again into detail into each SLR that we summarized for each one of these. So starting out with inflammation and endothelial function, this was an SLR and meta-analysis of 28 RCTs. So it's a very large systematic literature review and an analysis, minimum 4 weeks duration in the trial. They actually included trials that specified virgin or extra virgin olive oil, so there's a little bit more specificity relating to the quality of the oil and obviously to the phenol content. And what they found was actually that there were decreases in inflammatory markers. So we know that low-grade chronic synthesis and release of those cytokines like interleukin and tumor necrosis factor alpha, it affects the cell wall and it relates to atherosclerosis and CVD risk. So those inflammatory markers are directly related to cardiovascular disease in that mechanism. And the virgin and extra virgin olive oil resulted in a significant reduction in markers of inflammation, markers of endothelial function, but not significant for other factors like tumor necrosis factor and adiponectin. And that's because the number of studies for those were quite low. So there weren't enough RCTs done that measure those markers. It's really the only systematic literature review on olive oil, so perhaps it would be great to get more systematic literature reviews looking at the grade of olive oil as well and markers of inflammation. But there were a lot of issues with this SLR. The dose varied, the type of olive oil. A lot of the olive oil being consumed here was in capsule form, so actually wasn't in food form. The intervention included healthy and not healthy individuals. So obviously the ones that were less healthy would already have some sort of baseline chronic inflammation. So there are lots of limitations to this SLR to consider. The next one is blood lipids. We know that dyslipidemia and hypertension are probably 2 of the most important risk factors for cardiovascular disease. We know that olive oil has a high MUFA content, specifically oleic, but also it has a low saturated fat content. And therefore, it plays a role in cardiovascular prevention by lowering blood lipids that are detrimental to cardiovascular disease. So lowering LDL, total cholesterol, triglycerides, but also oxidation of LDL. Now, this was, again, a very large systematic literature review and meta-analysis of RCTs with a minimum of 2 weeks duration. And the reason why we chose this SLR and not Catherine's recent SLR on phenolics is because it compared to other plant oils. So it wasn't just comparing within olive oil, it compared olive oil against other oils. But hers, it's another great paper to read if you're interested in the effect of olive oil on blood lipids. It wasn't specific to blood lipids exactly, it covered cardiovascular risk factors as well. And what they found, it's actually a very hard meta-analysis to read and to interpret, and we've summarized it here for you, but if you go off and read it, you'll see that there's a lot of differences in findings based on subgroups. So they actually analyzed versus the type of plant oil versus if it was long-term or short-term, if it was older or younger, normal lipidemic or dyslipidemic subjects, and a lot of the results tended to differ depending which subgroup you were looking at. But overall, what this meta-analysis found was that olive oil clearly increased LDL, especially in the young, in the trials that were long-term, and those who were normal lipidemic. Other plant oils, in contrast, had a larger reduction. So olive oil and plant oils both reduced all the blood lipids, but other plant oils, particularly omega-3 ones, had a larger reduction than olive oil. And that difference disappeared in trials that were long-term. So if you look here on the right in this meta-analysis, what this is actually showing you, it's the effect on triglyceride, and virgin olive oil had a greater effect on lowering triglycerides compared to the control. But then when you look at the meta-analysis for total cholesterol, the opposite is seen. So refined olive oil actually had a greater reduction than virgin. So the results are slightly conflicting with the refinement, and it's probably because if you see on the bottom there are 9 studies that didn't state olive oil, and perhaps if they did and that was included, the direction of the relationship would be greater. Another point of perhaps why those differences are being observed is because the polyphenol content might not be the only thing. It's not just the fatty acid profile, but the polyphenol content may be collaborating and working together on that blood lipids reduction. So there's more to it than just looking at refinement versus omega-3 versus omega-3 and so on. And then the other subgroup meta-analysis that they did, you can see here that this is compared to olive oil. So olive oil and saturated fat-rich oils both had a lower reduction, a smaller reduction in LDL, total cholesterol, triglycerides. Now, blood pressure, the other risk factor for cardiovascular disease. In this particular SLR, it was actually on cardiovascular risk factors. It wasn't specific on blood pressure. We didn't find any study on blood pressure specifically. And even within this SLR, it actually compared high versus low phenolic olive oil, which is great, finally. We're finding more studies that are doing that. And there are only 2 studies that they identified that compared high phenolic to low phenolic olive oil. And in those 2 studies, it was very clear that it helped reduce systolic blood pressure and oxidative LDL levels in the high phenolic arm, but there was no difference in other lipids and no difference in diastolic blood pressure. This was a mostly Mediterranean diet study, so people were already using olive oil as their primary fat. Again, small number of studies, only 8, and the authors found high heterogeneity, so lots of differences in the intervention, in the dose, and the length of time, and so on, between the different studies. So it's important to take these results lightly, but there seems to be a very clear relationship that the phenols do tend to have a mechanistic effect on blood pressure as well, another risk factor for cardiovascular disease. And the last SLR that I'll be presenting is looking at weight loss on the med diet. So this was an SLR, it wasn't a meta-analysis, looking at 5 RCTs. So these were long-term RCTs greater than 12 months in overweight and obese adults. So when you look at the results, it's actually predominantly in obese adults. And they looked at weight loss, but also other cardiovascular disease risk factors. So pre-intervention, very clearly, there was a decrease in body weight and waist circumference. And then versus other diets, it was very clear that the Mediterranean diet was superior to a low-fat diet, but there was no significant difference to low-carb or the American Diabetes Association diet. So perhaps the diet that you're comparing to may have an effect on the results. But overall, it's effective to weight loss, but it depends which diet you're comparing it to in terms of the extent that it's superior. So some of the limitations that I'd like you to think about, all this research on the med diet and olive oil and the fact that we're trying to summarize it all for you, it's important, again, like I mentioned, that a lot of the science is on med studies only, and we know that by default, olive oil is the primary fat, but a lot of the evidence is actually there for med diet and not olive oil specifically. We know that there's a type of olive oil is important to consider. We really want to see more and more SLRs that actually include only those studies with the high phenolic olive oil, or actually do a comparison with the lower phenolic. It's important to take into account confounding and observational studies. So a lot of the studies, the individual studies, adjust for confounders, adjust for energy take, but not all. And when you're combining them all into meta-analysis, then that all gets washed out, and it's not really taken into consideration. When we're comparing it to something, again, it's important to compare to what kind of diet or to what kind of oil. Are we comparing it to palm oil? Are we comparing it to rapeseed or canola oil? What's the comparator food, diet, or control? And last but not least, it's important to determine, we need that research showing that the evidence is applicable to Australia and the Australian population. So going back to that lifestyle medicine focus on nutrition and fats, so what do we recommend? So some practice tips found in Gary's book, looking at providing nutritional advice with the whole assess, assist, and arrange. So you assess, for example, whether the diet is a significant factor, like I mentioned. Perhaps you assess what kind of diet they're actually on. Again, you assist them by educating them on healthy eating. You provide literature if needed. You help monitor their intake. And lastly, you arrange and refer to other people, other health professionals, and self-help groups. What is the lifestyle medicine recommendation in terms of nutrition? It's really not about eating less fat because it's energy dense. That's what we used to think, right? So, oh, it's energy dense, it's easy, let's just cut fat, and that will solve all our problems. But we need to be specific. So we know that the amount of monounsaturated fatty acid in the diet needs to either be maintained or recommended in place of saturated. But we don't want to tell people that. We want to just tell them to eat foods, right? So we want to encourage them to have extra virgin olive oil in their diet. We want them to have nuts in their diet, which are proven to help with cardiovascular disease prevention. And at the same time, to have seafood, we won't tell them to keep their N6-N ratio low. We want just to encourage that long-chain omega-3 intake. So my concluding remarks, take-home messages, what you get out of today is that we know that cardiovascular disease is largely preventable. It's unbelievable that it still exists, really, because we can prevent it. And we know diet is key to its prevention. But the problem is that pretty much 2 out of 3 people in Australia are not even close to meeting the Australian Dietary Guidelines recommendations and aren't really eating any diet that's conducive to good health. We know that more than 1/3 of our energy intake is coming from those foods that we should have seldomly, but we're having them daily. The other point is that diet adherence is actually a real issue to dietary intervention. So there's actually a systematic review and meta-analysis looking at weight loss interventions and showing that about 40% of people actually fail to adhere. And as Catherine just presented, recent research published this year, it's shown that the adherence rate to both extra virgin olive oil and nuts are quite high. So it's a really easy recommendation if you want people to adhere to the diet. Same in the Predimed study. In the olive oil arm, the percentage lost to follow-up over 2 years was only 3.6% compared to 11.3% in the low-fat. So it's a recommendation that's probably quite easy to do. People can adhere to it. And there's research published showing that adherence may actually have a greater effect on our health than specific medical therapy. So I want you to think back to that room and close your eyes and all those people that you love that are in there and go, could you perhaps prescribe extra virgin olive oil just like a pill or medicine? And we're looking at doses that are, the dose and the portion size is important. So all those studies are looking at around 25 grams at least per day. Can you make that recommendation? From a lifestyle medicine perspective, what happens when you consume olive oil? Well, you're probably going to be cooking something, or you're going to be adding it to a salad. And you're actually not, hopefully, not many of you actually have it from a cup or from the bottle. I certainly don't, but it's important to take that context of how it will be consumed. So perhaps if we recommend it just like a pill or medicine, a prescription, then it might replace some other foods that might not be so good. It might help people to start eating at home and cooking whole foods, and then it will have that effect on cardiovascular disease prevention. So I'd like to thank Tim Casatari, my research dietitian, who was the lead researcher with all this awesome work, and obviously the Olive Wellness Institute, who funded this research to be done. And if you are interested in lifestyle medicine, I have to put in a plug as a board member. Please click on lifestylemedicine.org.au, and we'd love to have you join a society of like-minded health professionals from all different areas to help advance prevention of lifestyle-related diseases. Thank you very much.
Thank you, Flavia. We've got a few reference slides. Conscious that we're a bit over time, so I apologise. I'll just wrap up really quickly. So we've had a few questions come through. We'll put those together over the coming days with the presenters and send you through a Q&A reference book with all the responses. So apologies, we've got no time to do that now. You'll all also get a link to the recorded webinar session so you can review the information along with a PDF of the slide content. If you've got any further questions, we'll stay online for a few moments. We've also got info@olivewellnessinstitute.org as on the screen now to take any further questions. And finally, we're just about to deploy a survey to get some of your feedback so we can try and always work to improve our offer. And so if you'd like to fill that out, and at the bottom, provide your postal address for everybody who's hung on despite us going over time, so we do apologise. You'll be eligible for the gift pack that we'll send to you within about 4 weeks' time. So thank you very much. Apart from that, we're all finished, and we hope you enjoy the rest of your afternoon.